This explainer is based on the literature review, Cervicogenic Dizziness, Diagnosis and Management, Cervical-Vestibular Interaction and Combined Therapy, published by Australian Dizziness Clinics, available at australiandizzinessclinics.com.
All right, let's jump right in. Welcome to part 1 of our 4-part explanator series on a notoriously tricky clinical presentation, cervicogenic dizziness. If you're a clinician managing dizziness, you already know exactly how frustrating this condition can be, not just for you, but for your patients who are desperately looking for answers.
So we have to start here. Why is this so hard to diagnose in the first place? Well, the truth is, there's absolutely no single confirmatory test for it. There isn't a quick blood draw or some simple brain scan that's going to give you a definitive yes. That means we're relying on a highly precise clinical framework, a strict process of exclusion paired with finding positive clinical signs. But here's the good news. Once you get that framework right, the diagnosis goes from blurry and confusing to confident, and more importantly, highly treatable.
Here is our game plan for today. 1. The diagnostic challenge. 2. History and clinical features. 3. The 3-step logic. And 4. Key clinical takeaways. We're going to build that workable framework today by exploring the sensory mismatch, filtering out those absolute red flags, and locking in the Wrisley criteria.
Okay, Section 1, the Diagnostic Challenge. Let's think about what's actually happening under the hood here. To maintain a stable head-on-trunk position while you're looking around or walking, your brain needs cervical proprioception, vestibular inputs, and visual signals to integrate flawlessly. But when you introduce neck dysfunction, say a joint issue, an old whiplash injury, or just chronic strain, it creates a sensory mismatch. Your brain doesn't just register that as neck pain. It interprets that corrupted cervical signal as unsteadiness. And while it might be a small mismatch on its own, it completely overwhelms the system when you combine it with reduced vestibular function, high visual demand, or even just end-of-day fatigue.
Moving on to Section 2, History and Clinical Features. When you're trying to separate this from other pathologies, the patient's history is literally your sharpest tool. You have to listen very carefully to the words they use. Cervicogenic patients almost always describe a vague spatial disorientation or a floating sensation that's directly tied to neck movement or their posture. This is drastically different from true peripheral vestibular insults, like BBPV for example, where patients will describe an undeniable, intense illusion of spinning, usually triggered by sudden head impulses or positional changes.
What else should we be looking for? Well, the onset is usually quite gradual. We see it a lot following a whiplash injury or chronic postural strain from repetitive overload. You'll almost always find coexistent neck pain and frequently things like occipital headaches, visual disturbances, or even upper limb paresthesia. And here is a massive clinical pearl for you. You will constantly hear that these symptoms build up as the day goes on. If your patient says they feel horrible after sitting at a computer screen for 4 hours, but they feel totally fine after resting or changing positions, you really need to suspect a cervicogenic driver and examine that neck before chasing endless vestibular tests.
But actually, before we go locking in that diagnosis, we must filter out the red flags. This is completely non-negotiable. If your patient comes in with sudden onset true vertigo accompanied by nystagmus or sudden hearing loss, bilateral symptoms with dark-induced imbalance, or any focal neurology, you have to stop right there. You cannot label that as cervicogenic. Those flags are screaming at you to investigate further and rule out serious central or acute peripheral issues.
Which brings us to Section 3, the 3-step logic. So how do we take all those clinical clues and actually structure them into a bulletproof diagnosis? We use a diagnostic funnel. It's like a filter. You start right at the top with a patient presenting with unsteadiness, again, not true vertigo, and neck pain. From there, you systematically rule out all the competing systems before you even entertain the idea of confirming the neck as the primary culprit. Let's break those steps down.
Okay, here is the 3-step logic you absolutely need to memorize. Step 1. Rule out the vestibular system. Your objective testing, things like VHIT, caloric tests, and VEMPs, they must be normal. Step 2. Rule out the central nervous system. Their history, the neuroexam, and any indicated imaging must be completely clear. Step 3. Only after you've cleared those other systems, then you look to confirm the cervical drivers by finding positive clinical signs in the neck. And following that exact logic leads us straight to the Wrisley criteria. This is the gold standard framework here. It strictly requires all 3 of these elements to be present. Number 1, neck pain. Number 2, dizziness related to neck movement, not head impulses, but neck movement. And number 3, the absence of confirmed vestibular pathology on objective testing.
Once those vestibular and central systems are totally ruled out, we have to actually confirm the cervical contribution. We do this through a highly targeted assessment battery. You're looking for positive, objective findings in tests like the joint position error test, the smooth pursuit neck torsion test, checking for cervical range of motion deficits, and doing specific segmental palpation. When those tests are positive across multiple domains, boom, they validate the Wrisley criteria and confirm that cervical dysfunction is indeed driving the dizziness.
Finally, Section 4, Key Clinical Takeaways.
I want to leave you with a massive clinical trap to avoid. Remember this quote: "True cervicogenic dizziness is rare in isolation. It is far more often part of a dual pathology." Please, don't just put your blinders on and treat the neck. You should fully expect vestibular or migraine drivers to be running right alongside that cervical dysfunction. Take a standard whiplash patient. Sure, they have a neck strain, but they might also have BPPV from that exact same trauma. If you want a good outcome, you literally have to address both components in parallel.
So, let's summarize that funnel. First, rely on exclusion plus positive signs. Second, apply those Wrisley criteria rigorously so you aren't mislabeling anyone. Third, strictly follow the three-step logic to clear vestibular and central pathologies first. And fourth, always keep an eye out for dual pathology.
Up next, Part 2. In the next video of this explainer series, we're getting incredibly practical. We're going to dive deep into that cervical assessment battery, showing you exactly how to execute and interpret the joint position error test, smooth pursuit neck torsion, range of motion, and palpation. For additional resources, including the full literature review, the clinical cheat sheet, audio overviews, and the rest of this explainer series, visit AustralianDizzinessClinics.com. Please subscribe to the channel and leave a rating to support the series. Before you go, think about this. How many hidden dual pathology cases have you actually seen in your clinic just this week without even realizing it? Keep that in mind as you head back into the clinic.